Hmm. Open कर queries देख Okay, dear students, so I'm your psychiatry faculty, Dr. Dharmendra Singh. Today we will have a psychiatry session. We are having this program, this FMG Accelerate program. It's a very important one that because as you know that in Indian exams, including FMG, they usually target the particular topics in the all subjects. They don't change the topics; they just change the MCQ. So in every sessions, we try to discuss the important topics, and usually like in we had NEET PG exam, and that time I discussed the psychiatric. We had a psychiatry session, and in psychiatry session the all MCQs what we have discussed, they came from these sessions only. So be ready, let's start. In psychiatry, yeah, I accept that it's a minor subject, but in psychiatry basically usually they ask from this area, from this subject, at least 8 to 10 MCQs. And 8 to 10 MCQ including they ask the diagnosis of various psychiatric disorder, they ask the psychopharmacology. Nowadays we have a recent changes in DSM and ICD, they're also there. Okay, so the diagnosis, psychopharmacology, and the recent changes sometime the target. Okay, so let's start. In between I will try to discuss that how the what are the important topics, because in FMG the your approach should be little different. You should not be, you know, don't try to be knowledgeable, try to be a smart student, because out of 300 MCQs you have to do the 150, no minus marking, so if you have a good hold on a at least 10-11 subjects, you can be through this exam. Because after coming from there, on paper we have a 6 months, but usually you don't have a 6 months. You come, you get settled down, you join somewhere, you start study. So it takes, even you are a very sincere student, it takes almost 1.5 months, and then you start preparing for this exam. And so it's like only for 4.5 months. So it's completing the 19 subjects thoroughly in 4.5 months, it's impossible. So ये आपको समझना होगा कि you have to be smart student in FMG. Don't do, yeah, I usually told this in classes as well, you don't try to be very knowledgeable person, because if you will try for every subject, then yes, you will clear this exam, but the question is when, that will be difficulty. So 10-11 subjects, the minor and basic subject is a backbone of any exam including FMG. So in psychiatry, we will go through these MCQs, the previous year MCQs, and we will cover the various topics through these MCQs only. And in between, if you have any queries, please let me know. Any related, any topic you want to ask, particular MCQ, any query you have exam related, I will be happy to cover all these your topics and queries. Okay. The question number one, a middle-aged person with symptoms of sadness and feeling of loneliness was diagnosed with the depression. He is to be prescribed with a medication which is serotonin norepinephrine reuptake inhibitor. Identify the drug. Okay. So in this, every time they usually ask one MCQ from the antidepressants. We have various antidepressants. Here they ask the example कि भाई SNRI के बारे में बताओ. You tell about SNRI. Serotonin norepinephrine reuptake inhibitors. The example of serotonin norepinephrine reuptake inhibitor is, we have venlafaxine. Okay, we have venlafaxine, we have des venlafaxine, and we have duloxetine. We have melna sepra. Okay, and levomelna sepra. So venlafaxine, desvenlafaxine, duloxetine, melna sepra. So venlafaxine, in this MCQ the answer will be B. Venlafaxine, serotonin, norepinephrine, reuptake inhibitor. The side effect of venlafaxine, we have increased blood pressure. Duloxetine, apart from as an antidepressant, we also use diabetic neuropathy. Diabetic neuropathy, you can say various neuropathic pain including diabetic neuropathy. Okay, yeah. Duloxetine, I don't think that much difficult they will ask, but just remember that in somatic pain also it's very important antidepressant. Somatic symptoms, when we have a somatic symptom or physical symptom, so sometimes people have a psychological distress, they present the psychological distress in a physical way, and they, rather than complaining about the psychological symptom, they complain about the physical symptoms. Or I have a body ache, I have a headache, abdominal pain, various somatic symptoms. In that, duloxetine is a very effective antidepressant. Briefly, antidepressant is an important topic, so if you want, we can go through this topic. We have SSRI, selective serotonin reuptake inhibitor. This is what we have: escitalopram, we have citalopram, we have fluoxetine, we have fluvoxamine, okay, we have sertraline, and we have paroxetine. Okay, this is only selective serotonin reuptake inhibitor. In this, just remember, the fluvoxamine is a drug of choice in obsessive compulsive disorder. That MCQ they usually ask. Sertraline is safe in pregnancy. The safest, you can say, SSRI in the pregnancy. It is safe in breastfeeding female. Okay, it is safe in a breastfeeding female. It is also safe in elderly people. So these type of MCQ also pregnancy related. Nowadays we are talking a lot about the next, so the clinical oriented MCQ, they can give a description of pregnancy, and then they can ask that which antidepressant is preferred. Your answer will be sertraline. Yeah. Paroxetine, what they can ask, paroxetine is a basically it also has a action on a H1 receptor, histaminic receptor. That's why it gives good sedation. So paroxetine, usually SSRI, which we otherwise SSRI we give in the morning, but paroxetine is a SSRI we prefer in the night. You basically give in night, so you give the patient, it acts as an antidepressant also, and it gives a good sedative effect. We have a side effect of SSRI, sexual dysfunction, and one of the sexual dysfunction is what? Delayed ejaculation. So the paroxetine also has a side effect of delayed ejaculation. So you can remember that paroxetine we can use in a treatment of what? Premature ejaculation. We can use in a treatment of premature ejaculation. We use side effect delayed ejaculation. Okay, so this is SSRI. We have SNRI. We have one NDRI, norepinephrine dopamine reuptake inhibitor, that is bupropion. Okay, bupropion. In bupropion, basically it is as a anti-smoking agent we use, as anti-smoking. It is sexually safe, so you can say it has a least sexual dysfunction. Okay, and it is contraindicated in epilepsy. If they ask the tough MCQ in bupropion, till now they did not ask, but in future it can be asked that basically we have a case of bipolar disorder. In bipolar disorder, patient when having a depressive episode. So patient currently having a depressive episode, but he's a known case of bipolar disorder. In that case, we have to prescribe the antidepressant, but which antidepressant will prefer? We'll prefer the antidepressant which has a least chance of switch. So that please remember, this MCQ they did not touch till now, but least chance of switch. Switch means switch into mania, you can say mania. So person is having bipolar disorder, currently person is having a depressive episode, and you prescribe the antidepressant under the cover of mood stabilizer. Which antidepressant is having a least chance of switch? Bupropion. Please remember, it's a very important MCQ. Till now they did not touch this, but in future they can ask. If they ask the maximum chance of switch, your answer will be venlafaxine. Venlafaxine. So maximum chance venlafaxine, least chance is what? Bupropion. Okay. Yeah. Okay. So antidepressant, we have even mirtazapine, many others, but important one, just one important MCQ I will just tell you here, and then we'll go further. And that is what? According to sexual dysfunction. This MCQ they ask again and again. So bupropion has least chance of sexual dysfunction, least chance. So bupropion is less than mirtazapine. Mirtazapine is less than venlafaxine. Venlafaxine is less than SSRI, and SSRI is less than DCA, tricyclic anti. So they can ask least chance, then your answer will be bupropion. If bupropion is not in an option of, then you go for mirtazapine, then the venlafaxine, then the, so bupropion is having a least chance of sexual dysfunction, okay, and maximum chance we have what? Maximum chance we have ITCA, tricyclic antidepressant. Okay, yeah. Very good evening. How to treat bipolar disorder? Okay, don't worry. We'll talk about that. We'll just the MCQ will come, and we'll discuss about the bipolar disorder. Okay, so I have MCQ there. That time we'll discuss about the bipolar disorder. Okay, yeah. So this is the MCQ number 1, and that MCQ is what? So I will go in the, so we have MCQ number 1 is a middle-aged person with symptom of sadness, feeling of loneliness or depression, and the prescribed with the medication which is as SNRI. Answer is venlafaxine. Fluoxetine, it is SSRI. Citalopram is also SSRI, and phenelzine we have some MAO inhibitors. Okay, yeah, monoamino oxidase inhibitor. Done. Question number 2. A 28-year-old mother was diagnosed with the mild depression. She has a 3-month-old child. Which among the following should be preferred? Cognitive therapy with the antidepressant alone, electroconvulsive therapy. So basically, that when the breastfeeding mother having a chance of side effect due to the antidepressant or any other medication, and the child also can have because child can feel drowsiness or other side effects. So better if we can avoid the medication, but we have to see the risk and benefit ratio. So if they mention the mild depression, then your answer will be what? Cognitive behavior therapy. So in mild depression, if they give you the symptom like, so question number 2, if they give you description of mild depression, then you will go for CBT, cognitive behavior therapy. But if they talk about the moderate depression and further, then you will go for the will go for the medication or antidepressant. Antidepressant. As I already mentioned that uh, after in breastfeeding female, the which antidepressant is safest, sertraline, SSRI. This is a safest antidepressant. Okay. In delivery, that also please remember that they are asking sometime. Basically, what happens that we have postpartum blues, postpartum depression. Okay. So after delivery, we have postpartum blues in the roughly 30 to 75% female. Okay, and the postpartum depression we have roughly in a 10 to 15% female. In postpartum blues, we have basically the symptoms are irritability. Patient will have irritability, chidchadapan, sleep disturbance. Okay, sleep disturbance and crying spells, rona aata hai. These are the symptoms in postpartum blues, not severe depressive symptom, only these symptom. The onset of postpartum blues is around 3 to 5 days after delivery, and the symptom automatically subside within 2 weeks. In 2 weeks. Okay, and so no medication is required in postpartum use. Please remember, no medication is required, only support to mother is sufficient. That you have to know. So what are the symptoms they are giving? When the onset, they are telling in postpartum blues, just 3 to 5 days after delivery we have onset of postpartum blues. These are the minimum irritability, sleep disturbance and crying spells we have, and these symptom automatically resolve, get subside within 2 weeks, and there is no medication is required in postpartum blues. Most common, you can say, psychiatric disorder after delivery. If they talk about the postpartum depression, then we have, yes, within 1 to 3 months after delivery we have the proper onset of the depressive symptoms. We have a proper episode of depression, and in that, yes, we give the medication. The onset is roughly like within 2 weeks. The examiner will talk about the depressive symptom, and then he will give the full picture of that depressive episode, and then he either will ask what's your diagnosis. He can ask that, okay, what is the percentage of postpartum depression after delivery, 10 to 15%, or he can say that, okay, which medication you prefer. Sertraline as a SSRI is the most preferred antidepressant after delivery. So in this MCQ, the mild they are having. Okay, so any queries, you have till now? Clear? The third MCQ will go for third MCQ is, which among the following is not a symptom of panic attack? Which among the following is not a symptom of panic attack? So the panic attack, so you can say panic attack is a like extreme picture of anxiety symptoms. Panic attack basically when the patient having a panic attack, we having the symptom increasing, and then the symptom goes in a peak, and then they again symptom subside. The peak of panic attack we have within 10 to 15 minutes. In 10 to 15 minutes. What are the symptoms in panic attack we have? We have a two type of symptoms in panic attack. One is we have somatic symptoms, one we have psychic. Okay, somatic symptoms like we have dryness of mouth, Patient will have palpitation. This MCQ they ask again and again, so we'll discuss little in a detail. Palpitation. Patient will have respiratory difficulty. Okay, respiratory difficulty. Patient will have some bloating sensation, abdomen. Okay, पेट में गुड़गुड़ लगता है. Patient feel having sweating. Okay, some kind of restlessness. These are the, and patient even can have a diarrhea or diarrhea like symptoms. These are the somatic symptoms. And we have a psychic symptom. Psychic symptom is what? Apprehension. Person is apprehensive. Like suppose today patient had a panic attack, will increase. Patient will feel like impending doom. This word examiner is impending doom. Again and again they are using these words. Impending doom. Patient is not extreme anxiety, feeling of impending doom that today I am going to die, today is my last day, and then anxiety gradually subside. This is a one episode of panic attack. So these are the somatic, physical, body related symptoms, sharir se sambandhit, and we have a psychic symptom, apprehensions, impending doom, or today I am going to die. Patient will have a various thoughts. Okay, any query having? Okay. 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 And whenever we have a panic attack, we have to find out the rule out the causes. So this MCQ also they are asking again and again that what are the organic causes of panic? What are the organic medical causes? So the organic or medical causes are, we have patient have hyperthyroidism. Okay, hyperthyroidism. Patient having a hypoglycemia. Person can have epilepsy, carcinoid syndrome. Okay. Arrhythmia. Okay, arrhythmia, carcinoid syndrome, arrhythmia, mitral valve prolapse, mitral valve prolapse, pheochromocytoma. Okay, these are the some important organic causes of panic attack. Patient can have panic attack due to these medical conditions. So either they give the description of panic attack and then they ask that okay, what are the organic causes of panic attack, except they give the directly cause, or they give what all investigations you would like to do, except. So investigations, yes, in to rule out the hyperthyroidism, what you do, thyroid profile. To rule out the hypoglycemia, what you will do, blood sugar level. Okay, blood sugar level. Epilepsy, you can do electroencephalogram. Okay, arrhythmia, usually we do what, ECG. Pheochromocytoma, you can do the 24-hour catecholamine level. 24-hour catecholamine level. So these are the basically, either they will give you direct organic causes they will ask, or they will give you some investigations. Usually whenever they give the investigation, one option they give complete hemogram. And complete hemogram is nothing to do with the panic attack. So usually this will be the answer of exclusion. Okay, complete hemogram. When you don't have any organic cause, then it's a functional cause, then it's a psychiatric cause. So then we say that it's a psychiatric disorder. And the 4 panic episodes patient having in 1 month, then we say the person is suffering from panic. So 4 panic episodes in 1 month, then we call it a panic disorder. Okay, panic disorder. If they ask you the treatment of choice in panic disorder, your answer will be CBT, cognitive behavior therapy. If they ask you the treatment of choice is CBT. If they ask you the best modality of treatment, then your answer will be CBT plus SSRI plus benzodiazepine. So the benzodiazepines, SSRI also we use to target the symptoms. So treatment of choice is cognitive behavior therapy. The best modality is a medication plus psychotherapy, CBT. Okay, so you have to see the language. Okay, we have one medication, buspirone. So please remember, we have bupropion and we have buspirone. Buspirone is a 5-HT1A partial agonist. 5-HT1A partial agonist, and bupropion is a what? Anti norepinephrine, dopamine. Okay, yeah, correct. So buspirone is an anti-anxiety drug and bupropion is a antidepressant. That they can ask. Okay. So in this is a MCQ they ask. So please remember that the question number 3, which among the following is not a symptom of panic attack? Your answer will be, so suicidal thoughts, sweating, palpitation, tremor. Yes, sweating we have, palpitation we have, tremor we have. Suicidal thought is not a, so in question number 3 answer will be a. Suicidal thought is not a symptom of panic attack. So in these symptoms, then the treatment they can ask organic causes. This MCQ again and again they are asking. So be very careful about it. Question number 4, which among the following deficiency is the reason for cognitive impairment in the old age? And the answer will be what? Vitamin B12. Well, okay, we have high cobalamin, have a cyanocobalamin. Okay, we have a plasma form of vitamin B12 and we have a storage form of vitamin B12, cyanocobalamin. Vitamin B12, the very important vitamin. It helps in a DNA as well as RNA synthesis. Okay, RNA synthesis. It helps in a myelination. जो membrane होती है nerve के ऊपर की, वो it helps to synthesize it, and that's why basically the deficiency of vitamin B12 is one of the reason of what? Cognitive impairment. Okay, so question number 4 answer is B for Bombay. That will be B. Question number 5, a chronic alcohol patient suddenly withdraws his alcohol consumption. Later he developed tremor, global confusion, ataxia and other associated symptoms. Which among the following is the most appropriate treatment? So first you have to understand that what's the description is given and what's the diagnosis. So chronic alcohol patient, so examiner giving you hint that person is alcohol dependent. Suddenly he abruptly stopped the alcohol consumption. Then person developed the tremor, global confusion, ataxia and other associated symptom. We have one condition. So question number 5, we have one condition and that is what? Wernicke's encephalopathy. Okay, we have one condition and that is what? Wernicke's encephalopathy. Wernicke's encephalopathy. In Wernicke's encephalopathy, basically we have vitamin B1 thiamine deficiency. Okay, MCQ number 2. Because of vitamin B1 or thiamine deficiency, we have a lesion in mammillary body, and dorsomedial nucleus of thalamus. Okay, thalamus. Because of that, person will present with the symptom, and symptom is what? Gova. The very important topic, so they can ask, so be very careful about this. They are targeting again and again. G for global confusion. Okay, global confusion, or we can say what? Delirium. O is what? Ophthalmoplegia. A is what? Ataxia. Okay, ophthalmoplegia is due to sixth nerve palsy. Okay, sixth nerve palsy. So it's a abducens nerve palsy, and because of that we have a, it supplies the lateral rectus muscle, so it's a bilateral lateral rectus palsy. Okay, that you have to, sometime they can ask, so you have to remember, and ataxia. Okay, so the MCQ number 1 in this area, that which vitamin deficiency causes the Wernicke's encephalopathy? Thiamine, vitamin B1. What are the area which get affected in brain? In Wernicke's encephalopathy, mammillary body and dorsomedial nucleus of thalamus. What are the symptoms? Global confusion or delirium, ophthalmoplegia due to sixth nerve palsy, and ataxia. Okay, yeah. And then they can ask that in treatment what you will give. See, this is a tricky MCQ. Sometimes they ask, suppose that you made a diagnosis of Wernicke's encephalopathy. Now the nursing staff is nearby you. She is asking, sir, I have thiamine also, I have glucose also. What to give first? Usually the students give the answer, sir, glucose. See, there is a thiamine deficiency. Now you will glucose. Glucose कहाँ पे जाएगा? Glucose will go in a glycolysis. Glycolysis have enzyme which using vitamin B1 as a coenzyme. So there is a further depletion of thiamine, and there will be further worsening of the symptom. So please remember, if you give glucose first, patient condition going to get worsen. So what you will give first? You will give first thiamine. We give around 1000 milligram IV thiamine. Around 1000 milligram IV thiamine we give first, and when the patient, of course we will give glucose thereafter, but we have to push the, sometimes we do this mistake that people push the thiamine injection in the glucose bottle. That is also a mistake. Okay, yeah. So basically you give the, okay, you give the thiamine first, and then you give the glucose. If they ask you the first symptom which is going to respond to the treatment, ophthalmoplegia. Okay, ophthalmoplegia. Within few hours we have improvement, and if you treat these patient very sincerely, 50% patient have what? Residual. 50% patient have residual attack. Okay, yeah. So this is, you have to remember. If these patient either don't come on a time, or we are not treating them sincerely, then these patient can convert into what? They can convert into Korsakoff psychosis. Okay, Korsakoff psychosis. So it is same. It is also due to vitamin B1 deficiency. The lesion is also same. What? Mammillary body, and dorsomedial nucleus of thalamus, but only you can say that it's a more severe condition compared to Wernicke's encephalopathy, more severe condition. So in patient in this condition will have what? Personality changes. Person will have what? Personality changes. Personality changes. Correct? Personality changes. And big patient will have what? Amnesia. Memory disturbance. Basically, usually we say that all conditions having a retrograde amnesia more than anterograde amnesia, but Korsakoff psychosis is one of the few conditions which has an anterograde amnesia more than retrograde anterograde amnesia more than anterograde more than retrograde, and they have what? Confabulation. Confabulation. What is confabulation? Basically, patient having a memory disturbance. Patient has a memory loss in Korsakoff psychosis. You ask something about the past, patient forgot about it, but patient also forgot that he forgot. पेशेंट भूल जाता है, लेकिन वो ये भी भूल जाता है कि वो भूल जाता है, and that's why patient having a this condition confabulation, that because he forgot, and but he also forgot that he forgot. So what he does, he try to make a false story. So what is confabulation by definition? That it's a filling up memory gaps by false. Okay, filling up memory gaps by the false memory is what? Confabulation. Okay, please remember, the Korsakoff psychosis is not completely irreversible. It is not completely reversible condition. So it is, partial, half. It depends on the severity of the symptom. But if they say all of the following are true about Korsakoff psychosis, except, and they mention that it is completely irreversible condition, no, it is not. It is partially or half irreversible. Okay. Okay. So this is the. So we'll go for the MCQ, and the MCQ was chronic alcohol, suddenly withdraw alcohol consumption, develop the tremor, global confusion, ataxia, and other associated symptoms. Which among the following is most appropriate treatment? And answer will be what? IV or IM thiamine. Okay. So question number 5, answer will be B for Bombay. Answer will be B for Bombay. Okay. Yeah. IV thiamine we will give first. Question number 6, most common symptom of alcohol withdrawal. Okay, so this is also area they ask again and again. I will cover little in detail because they can again 100% they are going to target. One person we have alcohol dependent. Okay, so in alcohol dependence, person suddenly stop the alcohol, and we have a withdrawal symptom. These withdrawal symptoms, we have simple withdrawal symptoms, and we have a complicated withdrawal symptom. Simple means simple, less severe. Complicated means what? More severe. They are the serious. If you will not treat them on a time, patient can have very dangerous consequences. So simple withdrawal symptoms are tremor, increase blood pressure, palpitation, nausea, vomiting. Okay, nausea, vomiting, sweating, sleep disturbance. These are the simple withdrawal symptom. Okay, we have a complicated. Complicated means more severe, more severe. In complicated withdrawal symptom, again and again they are asking some or other MCQ. The first complicated withdrawal symptom is we have alcohol withdrawal seizure. 1000 times this MCQ has been asked. What they ask? The first MCQ in this area is peak of alcohol withdrawal seizure. The peak will be 12 to 48. Patient stop the alcohol. Patient stop the alcohol. Now after, between 12 to 48 hours after quitting or stopping the alcohol, person can have alcohol withdrawal seizure. So this, duration is important. They can ask you, and you have to be careful that what duration is given about after stopping alcohol. Okay. Second, alcohol withdrawal seizure is always in a continuum. 2, 3, 4 episode can be together. So that's why it's a dangerous. So once my humble request, please remember, for this is also take home message from a in a clinical practice. Basically, always tell the family members once they have any patient of alcohol dependence. Usually family members get frustrated. What they do, they don't allow the patient go outside. They try to lock him in a room, bahar nahi jane dete, and suddenly patient because of this withdrawal symptom can have a seizure, and this seizure can be dangerous because, again I'm repeating, we don't have a single seizure, we have a multiple 3, 4, 5 seizure in a continuum after stopping alcohol, and that can be dangerous. Patient can die. So you have to treat these patients. So peak is between 12 to 48 hours. The treatment of alcohol withdrawal seizure is what? IV diazepam. IV diazepam. Okay, IV diazepam. No anti-epileptic. Please remember, no anti-epileptic. Usually we have to take a good history that whether patient before started alcohol, whether he had a seizure episode or not, whether he's having a family history of seizure or not. Always there is a family member will give the correlation that जैसे ही सच शराब छोड़ता है इसको दौरे पड़ जाते हैं. Patient stop the alcohol and he is having a episode of seizure. So you have to establish the correlation. You have to make a diagnosis that whether it's alcohol withdrawal seizure or it's an independent epilepsy. If it is alcohol withdrawal seizure, then you have to give the only your aim is to terminate the episode, no anti-epileptic. Sometime we as a doctor we do this mistake, and once you start the anti-epileptic you have to give that at least for 3 years. So don't do this mistake. Once it's a alcohol withdrawal seizure, just IV diazepam to terminate the episode. Second complicated withdrawal symptom is alcohol withdrawal. Okay, alcohol withdrawal delirium. As I mentioned, that alcohol withdrawal seizure delirium is peak is between 2 to 5 days. 5 days, and maximum up to 7 days. Okay, 7 days. Between 2 to 5 days, maximum up to 7 days. So after stopping alcohol, within 7 days, the patient goes into the delirium. Then the answer is what? Alcohol withdrawal delirium. Why it is important? Because please remember, so up to 7 days, like before 7 days and after 7 days. Okay, after 7, before 7 days, it's a alcohol withdrawal delirium. After 7 days, see, after 7 days is not alcohol withdrawal delirium. You know that vitamin B1 deficiency, thiamine deficiency causes the Wernicke encephalopathy, and most common cause of vitamin B1 deficiency is what? Chronic alcohol consumption. Okay, so if they give the history of delirium or everything, but they mention the duration that this delirium after stopping alcohol occurs at the 8th day, 9th day, 10th day, etc., then your answer will be Wernicke's encephalopathy. So please, the duration of the time is very important. So examiner giving you history that since 10 years, since 15 years patient taking alcohol, so he's giving you hint that person is alcohol dependent, and thereafter he mentioned that after stopping alcohol person is having a second day, third day, 72 hours, 82 hours, 96 hour. He mentioned that okay, person having a delirium, he gives the delirium like picture, and then he asks what's your diagnosis. Answer is alcohol withdrawal delirium. But if the other language is same, but they mention that the delirium occur after 8th day or 9th day, then your answer will be Wernicke's answer. Clear? Okay. The treatment, the drug of choice of alcohol withdrawal delirium is long acting benzodiazepine, and this is what diazepam and chlordiazepoxide. Correct. The third complicated withdrawal symptom we have what? Alcoholic hallucinations. Patient will say कि सर जब मैं शराब पीता हूँ मुझे कोई आवाज़ें नहीं सुन, जब मैं शराब छोड़ता हूँ मुझे आवाज़ें आने लग जाती हैं, इसलिए मैं शराब पीता रहता हूँ. Basically, what is alcoholic hallucinosis? The patient under the influence of alcohol, person is alcohol dependent, and after stopping alcohol, person will have a complaint of auditory hallucination. This auditory hallucination complaint will occur within 24 hours. Within 24 hours after stopping alcohol. So there are 2-3 MCQ. One MCQ in alcoholic hallucinosis, they can ask that which complicated withdrawal symptom appear earliest. Which complicated withdrawal symptom appear earliest? Your answer will be alcoholic hallucinosis. So the seizure is between 12 to 48 hours. The delirium is between 2 to 5 days, maximum up to 7 days, and alcoholic hallucinosis within 24 hours. Within 20, so it appear earliest. See, in alcoholic hallucinosis we have a hallucination. In delirium also we have hallucination. Then how we'll differentiate them? Basically, the cardinal feature, the main feature of delirium is what? Impairment of consciousness. Patient will be confused, patient will be disoriented. But in alcoholic hallucinosis, patient himself come to us and he tells that sir, I have a complaint of auditory hallucination. Basically, you can say that in alcoholic hallucinosis there is no impairment of consciousness. No impairment consciousness. Okay, no impairment of consciousness. Only complaint of what? Auditory hallucination. So these are the three important complicated withdrawal symptoms. So we have a simple withdrawal symptom and we have a complicated withdrawal symptom. Whether you have a simple or you have a complicated, on the basis of you give the treatment. Either you treat the patient on a OPD basis or you treat the patient as a inpatient, you admit the patient. Okay, so the treatment of alcohol dependence. In that we have, first we give the detoxification. Detoxification we do with the long acting benzodiazepines. Like diazepam and chlordiazepoxide. Roughly, if patient taking one bottle of Indian made foreign liquor means whiskey, vodka, we give roughly 40 milligram diazepam per day. 10 in the morning, 10 in the afternoon, and 20 in the night. And if the patient taking one bottle of country made liquor, deshi sharab, then we give the 30 milligram per day. 10, 10, 10. Okay. We complete usually detoxification within 2 weeks. Usually complete detoxification within 2 weeks. After we completion of detoxification, we give what? Aversion therapy. Aversion therapy. Aversion therapy is what? Disulfiram. Disulfiram. Give the disulfiram. Disulfiram, why we call it aversion therapy? Because disulfiram inhibits aldehyde dehydrogenase enzyme. Okay, it inhibits the aldehyde dehydrogenase enzyme, and because of that, alcohol we convert into acetaldehyde. Okay, and acetaldehyde we convert into, so alcohol we convert into acetaldehyde, acetaldehyde we convert into acetoacetate. Alcohol we convert into acetaldehyde, enzyme we use alcohol dehydrogenase. Acetaldehyde we convert into acetoacetate, enzyme we use what? Aldehyde dehydrogenase. If the patient is on disulfiram, what will happen in a metabolism of alcohol? Alcohol will convert into acetaldehyde, but acetaldehyde will not convert into acetoacetate, because the acetaldehyde which convert, the enzyme which converting the acetaldehyde into acetoacetate, aldehyde dehydrogenase, will be inhibited by disulfiram, and that's why the patient will have a conversion of alcohol into acetaldehyde, but acetaldehyde further will not metabolized into the acetoacetate, and acetaldehyde will increase in our body. Okay, and we call it a what? We call it a disulfiram ethanol reaction. Disulfiram ethanol reaction. In disulfiram ethanol reaction, patient will have increased blood pressure, rash. Okay, so many symptoms. So that's why we call it a aversion therapy, because today suppose you took the alcohol on the top of disulfiram, you had a disulfiram ethanol reaction, next time even you look at the alcohol, you will have some kind of aversion. That's why we call it a aversion therapy. Basically disulfiram just bind the patient, but it doesn't decrease the desire to take the alcohol. It just bind the patient, that patient will have this fear that if I will take alcohol I will get the reaction, but it doesn't have anything to do with the craving or desire to take the alcohol. पेशेंट कहेगा सर आपने मुझे बांध दिया, आपने मुझे आप मुझे डराते हो मेडिसिन देके, बट मेरी डिजायर का क्या, मेरी क्रेविंग का क्या? सो नाउअडेज वी हैव अ एंटी क्रेविंग एजेंट. Anti craving agent we have a composite. Okay, we have composite, we have clofen, we have naltrexone. Okay, a composite, baclofen. Okay, naltrexone we have Topira. Acamprosate, basically it is safe in liver disease. Why they ask this? They ask this MCQ because you know that patient came to you, patient is alcohol dependent, patient can have a very high chance of alcohol liver disease. So if from the first day you want to start the any anti-craving agent, you can start acamprosate. Okay, one MCQ also remember, we usually do the detoxification with the long-acting benzodiazepine, because long-acting benzodiazepine is what? Basically having a long half-life and person having a it can cover the withdrawal symptom nicely. But please remember that the diazepam is a contraindicated in alcohol liver disease. It is contraindicated in alcohol liver disease. So if the patient either come to you, patient doesn't have any investigations, or we don't have any investigation facility there where you are seeing the patient, or if the patient having a derailed liver function, in both case you will go for what? You will go for lorazepam. Go for okay. Lorazepam basically the short acting benzodiazepine. Usually we don't prefer, but it is safe in liver. That you have to remember. Safe in liver disease. So if they give you some deranged liver function test, or you don't have facility, in that case you go for the lorazepam. Otherwise, yes, we use long acting benzodiazepine. Okay, so these are the some MCQ you have to, some area very important one which you have to remember. Okay, so the MCQ number was 6. The most common symptom of alcohol withdrawal, it is tremor. So if they ask you the most common symptom, so they ask you most common symptom of alcohol, or if they ask alcohol withdrawal, or they ask most common syndrome. The most common alcohol withdrawal symptom is tremor. Most common alcohol withdrawal syndrome is what? Hangover. Hangover has a multiple symptom like headache, like nausea, tremor. Okay, so this is the hangover is the most common syndrome, and most common symptom is what? Tremor. Okay, clear guys? Any query you have? Yes, clear? Okay. The next is, a pregnant mother was given lithium. The child might be born with. So lithium is very, very again important drug. So question number 7. Okay. In exam, lithium is so important drug. If they don't ask the lithium, if the MCQ is not given of lithium, it means you can be sure that paper is going to cancel. So basically, I want to just I'm saying this because lithium is so important drug. Usually they ask this one MCQ from the lithium. Okay, so if you know the lithium, it means you have to prepare only for 299 MCQs, or you can say 149 MCQs, because you need only 150. So lithium, the mood stabilizer. Okay, lithium, the indications of lithium. What are the indications of lithium? That in which bipolar disorder, the one student was asking that, sir, what's a treatment of bipolar disorder? So dear, now we are discussing the treatment of bipolar disorder. Okay, so clear? Yeah, very good evening. Yeah, Epstein and Emily. Yes, correct. Very true. So basically, what are the indications of lithium? Number one, the family history of bipolar disorder. Family history of bipolar disorder. Patient came to you, you made a diagnosis of bipolar. Now you took a family history and somebody was suffering from bipolar. Whether they received lithium or not, the diagnosis is the drug of choice is what? Lithium. Second, no comorbidity. No comorbid. Basically, bipolar disorder having a comorbid psychiatric conditions like substance use disorder and personality disorder. So usually the bipolar disorder has comorbidity, but when there is no comorbidity, it's a pure bipolar disorder, then we go for the lithium. Has neurotherapeutic index. कोई भी ड्रग जिसका neurotherapeutic index होता है, dear students, basically we have to check the level of that drug. Okay, why? Because minor increasing the dose can cause toxicity. Minor increasing dose can cause toxicity. Okay, yeah, correct. So we have we have to check the serum lithium level. We have to check the serum lithium level in an acute phase and in a prophylaxis phase. The acute phase, we have zero point 0.6 to 1.2 millimole per liter or milliequivalent. Prophylaxis, we have 0.6 to 0.8 per, so 0.6 to 1.2 millimole per liter and 0.6 to 0.8 millimole prophylaxis. Okay, after 4 to 5 days we check the level of lithium. That MCQ they also ask that today you started lithium, when you are going to check the level of lithium after 4 to 5 days. If they give 4, 5, 6, 7, answer will be 5th day. When you will check after 12 hours of last 12 hours of last. Okay, like in night you have given around 10 p.m. and you give the in morning 10 a.m. after last dose, after like 10 p.m. you have given, in morning around 10:30 will check the, okay, check. Yes, the teratogenic side effect of lithium, we have abstain and abstain. But please remember, apart from that, we also have the some, yes, 12 hours after, yes, 12 hours after last dose. Yes, Achan Khan, it's a 12 hours after last dose. Some other common side effect of lithium are tremor, ataxia, okay, memory disturbance, acne, psoriasis, okay, acne, psoriasis, that you have to remember. It increases TLC, so we basically give in a treatment of what? Neutropenia. Also we give in a treatment of what? Cluster headache, okay. Also we give in a treatment of what? Ulcerative colitis. Sometimes they ask these tough MCQs. Okay, we also have hypothyroidism due to lithium. Sometimes we can have rare condition hyperthyroidism as well. Okay, it causes what? Nephrogenic diabetes insipidus. Okay. Nephrogenic diabetes, so hypothyroidism, in a rare condition it causes hyperthyroidism and nephrogenic diabetes insipidus. Okay, it also suppress the sinus, so it is contraindicated in a sick sinus syndrome. It is contraindicated in a sick sinus syndrome. That's why we sometimes they can ask that which investigations you would like to do before starting. You have to do the thyroid profile, okay, you have to do the renal function test, you have to do ECG before starting that you have to remember. Okay, briefly about the, they can ask about the valproate. Basically the teratogenic side effect is what? Neural tube defect. Neural tube defect. Apart from that, valproate causes the what? Increased liver function test, it causes the sedation, it causes weight gain, it causes thrombocytopenia. Okay, the rare side effect of valproate are what? Yeah, it causes the alopecia also. The rare side effect of valproate are pancreatitis, polycystic ovarian disease, Steven Johnson syndrome, okay, and carbamazepine also causes the neural tube defect. They ask you the safest mood stabilizer in pregnancy. Okay, in pregnancy, first our choice will be lamotrigine. Lamotrigine. If lamotrigine is not in an option, oxcarbazepine. Okay. If oxcarbazepine is not in option, okay. Valproate, sodium valproate is a basically it's a yeah. Okay. So lamotrigine is a safest mood stabilizer. If lamotrigine is not an option, then oxcarbazepine. If oxcarbazepine is not an option, then you have to go for the lithium. Please remember that lithium causes the Epstein anomaly. The ratio is far less compared to the valproate and carbamazepine causing the neural tube defect. Correct? Okay. So question number, now we are talking about we don't use lacosamide in the as a mood stabilizer. It's an anti-epileptic. Okay. In mood stabilizer we use only dear that we use lithium, we use valproate, we use lamotrigine, oxcarbazepine, carbamazepine. Okay, but not the lacosamide. Lacosamide is a basically anti-epileptic drug. Clear? Yeah. Yes. Lamotrigine is a first line. First line. Clear? So question number 7, answer will be C for Calcutta. C for Calcutta. Question number 8, uncontrolled and excessive sexual desire in men is called, and your answer will be what? Satyriasis. So satyriasis, they ask excessive sexual desire in if nymphomania, the excessive sexual desire in. So this is the area, the sexual disorder. Usually they ask in a sexual disorder. First, they can ask the sexual response cycle. Okay, sexual response cycle. That you have to. What are the stages of sexual response cycle? We have a desire. We have excitement. Okay, we have orgasm. We have resolution. These are the 4 stages of sexual response cycle. Okay. Then we have a various sexual disorder. Desire, we have a decreased hypoactive sexual desire disorder that they usually don't ask. They ask the in excitement. And this is what? Erectile dysfunction. Erectile dysfunction is a disorder of excitement stage. The sexual disorder of a excitement. And in an orgasm, we have a important one. They ask the premature ejaculation. From your exam point of view, you just remember that the erectile dysfunction in a excitement and the premature ejaculation in the orgasm. Okay. Okay, correct. Now in erectile dysfunction, few important. In erectile dysfunction, we have a psychogenic erectile dysfunction. We have physiological erectile dysfunction. Psychogenic erectile dysfunction is a Most common type, roughly 65 to 70% we have usually psychological, okay, and then we have physiological. Whether it's a psychological, whether it's a physiological, we have to rule out, we have to check the whether patient is hypertensive or not, blood sugar level, testosterone level, the free and total both testosterone. We go for the penile doppler and then we rule out whether it's a physiological or psychological. Also we have a morning erection during REM sleep. We have a genital tumescence or morning erection. It also indicates that person having most probably psychological erectile dysfunction. Whether it's a psychological, whether it's a physiological, treatment is what? Medication. See, we have 5 phosphodiesterase inhibitor. Okay. We have sildenafil, tadalafil. Nowadays we have surgical prosthesis if there is a permanent damage, okay. So these are they increase the blood flow. Nowadays we have some food ingredient, L-arginine and combination. They are also very helpful. They don't have usually side effect. Also we have sensate focus technique, and we have quiz sensate focus technique. We have for erectile dysfunction, and squeeze technique we have for premature ejaculation, okay. Sensate focus we have for erectile dysfunction. In sensate focus we teach the patient, he or she basically it's a couple therapy. So in sensate focus basically we teach the couple that initially they have to focus on other body excitement area of the body rather than genital area, and when they get calmed down, then they have to focus on for the genital area. Basically it's a sensate focus technique. And squeeze technique we have for the premature ejaculation. Before, the premature ejaculation definition was not defined, but in a DSM-5 first time they mentioned that if it is within 1 minute the person having a ejaculation, we call it a premature ejaculation, okay. So within 1 minute person having a ejaculation, we call it a premature ejaculation. Clear? Yeah. So in this, the question number 8, we have D for daily, okay. Question number 9, a patient have had a COVID infection around 3 months back. Now he presents with the complaint of excessive sweating, palpitation, and fear that he is about to die. The physical examination investigation don't reveal anything. What's the likely diagnosis? No. So already we discussed it in a detail. Is what we have? It is panic attack. Number 9 already we discussed in detail. Question number 9. Question number 10, after 72 hours of cessation of alcohol use, which of the following seen in the patient with the alcohol dependence syndrome? So 72 hours, I told you the alcoholic hallucinosis duration I mentioned within 24 hours. The alcohol withdrawal seizure I mentioned 12 to 48 hours, okay. So you can make a briefly can make a one table. Again and again they are asking this MCQ. So we have alcohol withdrawal seizure, alcohol withdrawal delirium, and alcoholic hallucinosis, okay. Peak 12 to 48 hours, between 2 to 5 days, and within 24 hours. So in this MCQ is given after 72 hours. So the most likely answer will be alcohol withdrawal delirium, or we call it a delirium tremens. Another name of alcohol withdrawal delirium is what? Delirium tremens. So answer will be question number 10. Answer will be D for Delhi. D for Delhi. Question number 10. Answer will be D for Delhi. Question number 11. A patient came with a history of visual hallucination and disorientation. He was a chronic user of alcohol and the last intake was 2 days back. What is likely diagnosis? So basically, visual hallucination, person is having a disorientation. Disorientation means, again what? The delirium. So in this MCQ, so that's why I was mentioning that this, addiction psychiatry is a very, very important topic. They are asking again and again, again and again. Okay, yeah. Tablet composite for aversion therapy. No. Composite. Tablet acamprosate, aversion therapy for alcohol. No, acamprosate is a basically it's a anti-craving agent. The aversion therapy is what? Disulfiram. Okay, so it's not acamprosate, it's a disulfiram. Aversion therapy. Acamprosate is a anti-craving agent. Anti-craving. Clear? Okay. So I was telling you that this addiction psychiatry is a very important drug, a very important topic. Apart from alcohol, sometimes they can ask you about the opioid. I will briefly tell you about opioid. You know, the synthetic, natural, you will read yourself. We have in a treatment of opioid dependence, and sometimes they ask the MCQ that what are the withdrawal symptoms in opioid dependence. So the opioid dependence, the withdrawal symptoms are, we have lacrimation, पेशेंट के आंखों से पानी गिरता है, rhinorrhea, patient having a water from the nose, increase blood pressure, patient will have body ache, patient will have diarrhea, okay? Patient will have pupillary dilation, okay, mydriasis, patient will have nausea, vomiting, sleep disturbance, okay. So these are the MCQ. They ask, sometimes they ask that, okay, you have all of the following are withdrawal symptom of opioid except, so rather than diarrhea they give constipation and that will be your answer, okay. Sometimes they rather than pupillary dilation, the mydriasis, they give the meiosis, so that will be your answer of exclusion. In a treatment of opioid dependence, we treat what? We have a two type of patient who are chronic, okay, severely dependent. We use the upre and methadone. In chronic and severe patient, we use buprenorphine and methadone. These patient will say, sir, either you give me my substance which I was taking, or you give me your medication. I need one of these two. So buprenorphine usually we use from 8 to 12 milligram per day. So suppose you settle down the patient on a 10 milligram buprenorphine, and that buprenorphine you continue for the long period of time. We call it a maintenance therapy. Call it a maintenance therapy. So basically, two MCQ they can ask you here. One is maintenance therapy. We use for which type of patient? We use for the chronic, severely dependent patient or IV drug user. Okay, and second, the MCQ they can ask that which medication you use for the maintenance therapy, and answer is what? Buprenorphine and methadone. Buprenorphine and okay. One important MCQ they can ask you here that cannabis, the cannabis in cannabis, basically the active compound of cannabis is what? Delta 9 tetrahydrocannabinol. Okay. Delta 9 tetrahydrocannabinol. This is the active compound. Okay. We have bhang, we have ganja, we have charas, okay, and we have hashish or hash oil. Bhang we get from the dried leaves, ganja we get from the female flower part, female inflorescence, and charas we get from the resinous extract. That MCQ also they ask. The cannabis causes the cannabis induced psychosis, which we call hemp insanity. Cannabis induced psychosis. Cannabis is a substance which causes more psychological dependence than physiological. So it causes more psychological than compared to physiological dependence. Physiological. Okay. What are the other substance which we have which causes more psychological than physiological? Lysergic acid, cocaine, okay, amphetamine. These are the other substance which causing more psychological dependence than physiological dependence. Among these, LSD is the most common substance which causes only psychological dependence. Only psychological dependence. Okay. Amphetamine causes paranoid like schizophrenia. Paranoid schizophrenia like syndrome. So paranoid schizophrenia like syndrome. Okay, this MCQ they can ask. We have some syndrome associated with the cannabis. One is amotivation syndrome. Person is not feeling enough motivated for his or her life. Person is having a run amok. Person becomes suicidal or homicidal under the influence of cannabis. Okay, and person having a flashback phenomenon. Flashback phenomenon also associated with the cannabis. Okay. In cannabis toxicity, we have redness of eyes, increased appetite, dryness of mouth, palpitation. Okay, this type of symptom. About nicotine, what they can ask? Nicotine, if they ask you most common substance used in India. Okay, most common substance abuse in and most common illicit substance abuse. So most common substance used in India, answer is what? Tobacco. Okay. Abuse and illicit cannabis. Cannabis, although we use more than legal, but it is illegal, illicit substance abuse. Okay. In nicotine, you have to remember that nicotine or tobacco, the withdrawal symptom. Withdrawal symptom. Usually all substances have a tachycardia, palpitation as a withdrawal symptom. In nicotine, we have what? Okay, so we have bradycardia as a withdrawal symptom. Correct? The treatment in nicotine, we have nicotine replacement therapy. In replacement therapy, we also use bupropion as an anti-smoking agent, and we use Wernicke as a Now 3 months therapy for nicotine dependence. Varenicline is a alpha 4 beta 2 partial agonist. Alpha 4 beta 2 partial, that MCQ they usually we have one side effect of varenicline, suicidal ideas. Sometimes they can ask, sometimes they can ask. Okay. Okay. Cocaine, you know, we have cocaine induced psychosis. Cocaine basically causes the nasal septum perforation. Okay. Cocaine plus heroin together we call them what? Speedball. Okay, that MCQ also there. So these are the important MCQ in addiction psychiatry they can. Okay, please remember, first time the gambling has been included in addiction psychiatry. So we have this, the gaming addiction, or you can say the gadget addiction. The first time have included in DSM-5 and ICD-11. Also gambling first time we have included in addiction psychiatry. The caffeine withdrawal symptom and the cannabis withdrawal symptom also first time have included in addiction psychiatry. These are the MCQ dear students they can ask. So question number 11 also will be alcohol withdrawal delirium. Question number 12, what is the commonest emotional state? Most commonest emotional state is what? Love. That you have to remember. This MCQ they have asked directly, so it is love. Most common emotion is love. Question number 13, a 21-year-old girl suspect that the college principal is making some conspiracy against her and is planning to fail her in the upcoming exam. She feels that other teachers have also joined the conspiracy and students are helping them too. What's the diagnosis? Delusion of persecution, delusion of reference, delusion of infidelity, and the Othello syndrome. Okay. Othello syndrome. Yes, the answer is what? Delusion of persecution. That is what? Delusion of persecution. This area they try to ask. Okay, so delusion of persecution, patient start thinking that what? Somebody wants to harm him, somebody wants to kill him. Okay, some conspiracy is going against him. This is what? Delusion of persecution. The some delusion they are asking delusion of reference. What is delusion of reference? Delusion of reference is basically the patient think that somebody is talking ill about him. सर व्हेन आई गो आउट, जैसे ही मैं बाहर निकलता हूँ, मेरे पड़ोसी जो लड़के हैं वो मेरी तरफ देखने लगते हैं. दे स्टार्ट लुकिंग एट मी, दे स्टार्ट दे कीप स्माइलिंग वाइल लुकिंग एट मी. वो मेरी तरफ जब देखते हैं तो हंसते रहते हैं. एंड सर वो मेरे बारे में कुछ गलत बातें करते हैं. आई एम प्रिटी श्योर दैट दे आर बेसिकली टॉकिंग इल अबाउट मी. दिस इज डेल्यूजन ऑफ रेफरेंस. ओके, वी हैव delusion of infidelity, or we also call it a Othello syndrome. Delusion of infidelity or Othello syndrome is basically patient think that the partner is unfaithful to him, or partner is unfaithful to him or her. This is the Othello syndrome or delusion of infidelity. Okay, that my partner is cheating on me, Othello syndrome. Also we have delusion of nihilism, or we call it a Cotard syndrome. Cotard syndrome of nihilism or Cotard syndrome. Patient start thinking that his or her physiological function are not working properly. Nothing. Many times this MCQ has been asked in your exam. The examiner will give you that person is suffering from low mood, and he will describe the severe depression picture, and then he'll say that okay, person is having a person started, he stopped eating and brought by the family member in the casualty. And when the doctor took the history, that person is start explaining that sir, my intestine is not working, that's why I am not eating, my the organs got rotten, mere organs sad gaye hain, that kind of language examiner will use, and answer will be what? Cotard syndrome or delusion of nihilism. Okay, we have some delusion of grandiosity, of grandiosity. Person start thinking that he's very powerful, he's very influential person, that's all. I know that Modi ji, everybody, I am a very influential person, delusion of grandiosity. He thinks that he's very rich, he's very powerful, he's very influential person. That type of word examiner will use. Okay, so these some type of delusion they can ask. Delusion, please remember, delusion is disorder of thought. This MCQ they ask. It's a disorder of thought. The delusion is a disorder of thought. Delusion in mental status examination we describe under thought content. We describe under thought content. Describe under thought content. Okay. So thought content we describe what? Delusion. This MCQ also they ask. The disorder of possession of thought. Possession of thought in mental status examination. And what we describe under this? We describe under this obsession. So obsession we describe under possession of thought. Delusion we describe under content of thought. Okay. Apart from obsession, we also have a thought insertion, thought withdrawal, thought broadcasting. Also we describe under possession of thought. And we have a disorders of perception. Disorder of perception, we have what? We have vision, illusion and hallucination. We have the disorder of perception. Possession of thought, we have obsession. Okay, so again I'm repeating, the delusion under thought content, obsession under possession of thought, illusion, hallucination under the disorder of perception. Clear? Okay, so question number, so you have any query? Okay, how to treat dissociative disorder? Okay, somebody is asking. How to treat dissociative disorder? Okay, dissociative disorder, basically we treat we have in dissociative disorder we do the basically supportive psychotherapy. Also we use the abbreviation, or we call catharsis. Okay, we use the sodium thiopental session, and the sodium thiopental session basically we a little detail the Freud divided the brain into the conscious mind, preconscious mind, and unconscious mind. Okay, the topographical model was given by the Sigmund Freud, and in that we preconscious the our mind it act as a barrier. So through the catharsis reaction, call one word we are using catharsis, or call it a abreaction. So through catharsis or abreaction, basically this barrier we remove. We use the sodium thiopental and we give slowly, and basically person this barrier we remove, as if this preconscious wala, and person talks about his or her unconscious conflicts, and that's how we help the patient. So we this MCQ they can ask abreaction or catharsis, so they can ask the supportive psychotherapy, and yes, there is a stress is there, depressive symptoms are there, so we use the SSR. Okay. Okay. So question number 13, answer is A for apple. Number 14, a 13-year-old boy was brought to the child psychiatry by the patient. The parents reported that the child lie frequently at home and in the school, misbehave with the teacher, often bullies younger kids. So there are what are the symptoms? The child lie frequently, at home, in school, misbehave with the teachers, often bullies younger kids, and has been caught stealing money on multiple occasions. This is the most likely diagnosis. So we have this is very important MCQ, dear students, that we have disruptive behavior disorder. Disruptive behavior disorder. In disruptive behavior disorder, basically we have conduct disorder and we have oppositional defiant disorder, ODD. Oppositional defiant. In conduct disorder, basically we have a symptom. In conduct disorder, person will have what? Disobey parents, frequent fights in school. So disobey, frequent fights. Okay, frequent lying. So as I mentioned, he's having a frequent liar, bullying, the stealing multiple time. Okay, yeah. Cruelty towards animal. Okay, गली में से निकलेगा, डॉगी को पत्थर जरूर मारेगा. So cruelty towards the animal. Basically, in conduct disorder also we have setting fire, violence, home. So violent behavior, setting fire. Basically, oppositional defiant disorder and the conduct disorder, usually we have a same symptom. Only the conduct disorder is more severe. So in conduct disorder, usually we have this setting fire, violent behavior at home with the parents. Uh, it's a conduct disorder. Basically, in a positional defiant disorder also we have other symptom, but setting fire at home, the violent behavior we don't, the breaking thing at home we don't have. So that you have to remember. Either if the examiner uses the word setting fire at home, the violent behavior with the parents, the breaking things at home, then the answer will be conduct disorder. Otherwise the answer will be oppositional defiant disorder. So symptoms are same. Basically, oppositional defiant disorder is a less severe child psychiatric disorder, and conduct disorder is a more severe, the disruptive behavior disorder. So in this MCQ question number 14, better the stealing money is there, the misbehave with the teacher is also there, the bullying the younger children, multiple occasions, stealing money, that is a better to go for the conduct disorder. Okay, better to go for the conduct disorder. So question number 15, a 31-year-old female with a history of recent divorce presented to the emergency with complaints of palpitations, sweating, heaviness, and pain in the chest. She has multiple similar episodes in the past few weeks. The blood investigations and ECG are normal in the past. Two, investigations reveal no abnormality. What's the next better step? So the answer basically, patient, the question number 15, basically the diagnosis is what? Panic attack. The diagnosis is what? Panic attack. So the first option, the admit for the detailed investigations. No, already investigations have been done multiple times and the all are normal. The use benzodiazepine for symptom relief directly. Benzodiazepine is not a nowadays your drug of choice for any condition, usually apart from this alcohol wala condition. So we don't use benzodiazepine much, use beta blocker only. No, start counseling session. So as I mentioned, the treatment of choice in panic disorder is what? CBT. So treatment of choice is cognitive behavior therapy, and if they ask the best modality of the treatment, their answer will be CBT plus SSRI plus benzodiazepine. So the combination of medication plus CBT is a best modality of treatment, but the treatment of choice, if they ask, the answer will be CBT. CBT, what other psychiatric disorder we have where the CBT we use? So we use in a panic disorder, use in a depression, okay, use in a post-traumatic stress disorder, use in a eating disorder. Okay, so we use in panic disorder, we use in a depression, we use in a PTSD, we use in a eating disorder. Okay, so this is a treatment of choice, CBT in various now we use the CBT in a various psychiatric disorder, and treatment of choice is CBT in the panic disorder. So question number 15 we have question number 15 we have answer will be before born. Okay, question number 16, excessive fear of getting contaminated, repeated washing, repetitive checking behavior, and excessive doubts are features of excessive fear of contaminated, repeated washing, repeated checking behavior, and excessive doubts are features of panic attack, agoraphobia, obsessive compulsive disorder, and generalized anxiety disorder. Number 16 will be C, obsessive compulsive disorder. Okay, so obsessive compulsive disorder also, they again and again they are asking this MCQ. So if they ask you the most common obsession is, answer will be contamination. Okay, if they ask you most common compulsion, answer will be, before it was washer, now it's a checkers. Okay, checkers. So this you have to remember. Okay, and yeah. So most common obsession is a contamination, most common compulsion is a checker. Before it was a washers, now it's a checker. Okay, OCD is also like a panic disorder. OCD is also a area or a psychiatric disorder where they usually commonly target. So which is a brain area, they ask sometime cortico striato cortico thalamic tract is involved in a OCD. Corticostriatothalamo cortical, yeah, corticostriatothalamo cortical tract. Corticostriatothalamo-cortical tract. Thalamocortical tract is involved. Okay, so we have orbitofrontal cortex, we have caudate nuclei, we have thalamus, we have again orbitofrontal cortex. Okay, is involved. Sometimes they ask. Okay, we have pandas infection, the pediatric autoimmune neuropsychiatric disorder associated with beta streptococcal, beta hemolytic streptococci. So the children who have a frequent throat infection, the pediatric, pediatric autoimmune neuropsychiatric disorder associated with beta hemolytic streptococci, they are basically having more chance of OCD in adolescent age group. If they ask you the treatment of choice in OCD, answer will be exposure and response prevention therapy. Okay, in exposure and response prevention, which is more important? Response prevention. If they give you the separate option, exposure and response prevention, then the response prevention is a better option, because you expose the patient to the situation. If you not prevent the response, patient will keep doing that action. Okay, so response prevention is more important than the exposure. This is a treatment of choice. If they ask you the drug of choice, then your answer will be fluvoxamine. Okay, and the combination of SSRI plus exposure and response prevention therapy, or SSRI plus CBT, is a best modality of treatment. Okay, psychiatric, usually the psychiatric disorder where we use the psychosurgery. Okay, psychosurgery, answer is OCD. Psychosurgery, although currently Mental Health Care Act bill says that psychosurgery is banned, but psychosurgery is we use in OCD. Okay, OCD patient having a very often the comorbid depression, so we say the secondary depression seen in OCD. That MCQ they ask, secondary depression seen in OCD. Okay, so some or other MCQ they are asking. Already I mentioned that the possession of thought, the obsession we describe in mental status examination under disorder of possession of thought, not the content of thought. Content of thought is delusion, and possession of thought is what? Obsession. Okay. Okay, so the question number 16, answer is C for Calcutta. Question number 17, a 37-year-old male report that after a sudden financial loss, he developed a certain symptom. He started feeling, fearful that someone about to harm him. He couldn't sleep or eat properly. He also began to hear voices of a female, and then the voices would abuse him and say that he was useless and should kill himself. His symptom started approximately 1 week. There was no relevant past history of drug abuse or medical condition. Which of the following is the most likely diagnosis? Schizophreniform brief psychotic disorder, schizophrenia, schizoaffective disorder. Okay, so in basically this MCQ is from the diagnosis of schizophrenia. So how we make a diagnosis of schizophrenia? In diagnosis of schizophrenia, we have ICD, have DS, have ICD, have in ICD we have two important diagnoses. One is what? We have schizophrenia, okay, we have acute psycho. Schizophrenia, the duration is 1 month or more. So for making a diagnosis of schizophrenia in ICD, the duration we require at least 1 month or more. And in acute psychosis, symptoms are there, but the duration is less than 1 month. So up to 1 month, we make a diagnosis in ICD, acute and transient psychotic disorder, acute psychosis, and the 1 month or more, we make a diagnosis of schizophrenia. In DSM, we have three important diagnoses. We have schizophrenia, we have schizophreniform disorder, we have brief psychotic disorder. Brief psychotic. Schizophrenia, we have the duration is 6 months or more. The schizophreniform, we have duration 1 to 6 months, and brief psychotic disorder, we have duration then. So brief psychotic disorder, the duration is less than 1 month. The schizophreniform, we are making a diagnosis is what? Okay, so schizophrenia, we have 6 months or more. Schizophreniform, we have 1 to 6 months, and brief psychotic disorder, we have duration less than 1 month. Okay, so in ICD, 1 month or more schizophrenia, less than 1 month acute and transient psychotic disorder. In DSM, 6 months or more schizophrenia, 1 to 6 months schizophreniform, and the less than 1 month brief psychotic disorder. Okay, and in DSM also, the DSM mentioned that out of these 6 months, if the patient having at least 1 month active symptom, still you can make a diagnosis of schizophrenia. So it's also like ICD, that 6 months criteria they are giving, but they say that out of these 6 months, if 1 month the patient has an active symptom, we can still make a diagnosis of schizophrenia. Okay, so in this MCQ, the answer will be basically the brief psychotic disorder. Okay, so question number 17, answer will be brief psychotic. Question number 18, a student was referred for a evaluation as he was having a difficulty in studies. On IQ testing, his IQ was found to be 55. What's a diagnosis? Okay, so guys, it's a very important MCQ. We have, the mental retardation. Okay, mental retardation. Now we call in a DSM-5, the new name of mental retardation is what? Intellectual disability. Okay, so we call it a intellectual disability. Okay, ICD, we call it a intellectual developmental disorder. Intellectual developmental. So what's a normal IQ? Normal IQ is 90 to 109. Normal IQ. We have, when we call it a mental retardation, the IQ is less than 7. Okay. IQ is less than 7. Okay, according to IQ, we divide the mild MR, moderate MR, we have severe, we have profound. Mild MR, we have IQ will be 50 to 69, moderate 35 to 49, severe 20 to 34, and profound less than 20. Okay, so 50 to 69 mild, 35 to 49 moderate, 20 to 34 severe, and less than 20 is what? Profound. That MCQ again and again they are asking. Okay, yeah, we have roughly 85%, we have mild, we have roughly 10% is moderate, 3 to 4% is severe, and roughly 1% is profound. Okay, mild MR is self dependent except stressful conditions. So they are able to survive themselves except in a stressful condition. Okay, They can study up to 6th class, mild mentally retarded child. Okay, the moderate can study up to 2nd class. Okay, the severe and the profound mental retardation, they can't study. Well, they can't study at all. Okay, the moderate can indulge in a semi skilled work. They can indulge in a semi skilled work. Okay, work under supervision. The severe and the profound mentally retarded child, they are dependent for each and everything on others. Okay, if the treatment you will ask, the we have a contingency management. Okay, contingency, we have a contingency management means we have a action and we have reward associated with this action and reward. Like, we teach the child particular, suppose how to wear a shirt, and then every day we tell that I will give you 10 rupee if you will wear the shirt on your own. This is contingency management. We attach the reward to increase that action. This is contingency. Okay, please remember the Down syndrome, the most common chromosomal disorder associated with the mental retardation. Down syndrome. Apart from that, we have the Fragile X syndrome. Okay, another chromosomal abnormalities associated with the mental retardation. We have some metabolic disorder like phenylketonuria, like we have a Lish-Nihan syndrome. Okay, we have galactosemia. So galactosemia, Lish-Nihan syndrome, phenylketonuria, okay, adrenoleukodystrophy. These are the some metabolic error disease we have associated with mental retardation. Okay, so mental retardation, another name is intellectual disability. This MCQ they usually ask. Okay, so today I hope we covered the important the areas in psychiatry. Tomorrow also we have the class, dear students, at the same time. If you have any queries, so please be prepared and tell your other friends also to join, because it's important. In a short period of time you can target the multiple areas and multiple important topics. Okay, I hope you enjoyed this. uh, Again, I'll tell you, as a faculty, as a psychiatry faculty, that the in FMG exams you have to be uh, very focused that I have to clear this exam. Don't be, as I mentioned earlier in a starting of session, that don't try to be knowledgeable. Be a smart student, that how to get this 150. And in 150, if you want to be superficial in all 19 subjects, then you will never get it. So better be good in a 10-11 subjects rather than superficial in a 19 subjects. Okay, so basic, yes, if you are good in a basic and minor subjects, then you can clear this exam easily. Minor subject like psychiatry, the ortho, skin, radio, anesthesia, even forensic, you can say that these are the subject where they ask the at least total 55 to 65 MCQs, and these subjects you can revise very fast with the less effort. The maximum output is there. Okay, so tomorrow again we will have a session, a psychiatry session. So be prepared, prepare the any topic you want to ask. Okay, hope to see you tomorrow again. Okay, have a great evening. Bye bye, take care. Thank you. Tomorrow we'll start from the 19th MCQ. 19th